Hello, I'm Gabriel Steck from Hôpital Bichat in Paris, and it's my pleasure to welcome you to this editorial discussion entitled Catheterization Access Sites Post-Rival. I'm here today at the EuroPCR 2011 in Paris, and I'm joined by Dr. King from Atlanta, Dr. Maron from New York, and Dr. Nolan from Stoke-on-Trent in the UK. And we're here to discuss the results of the RIVAL trial, a large randomized study which really tried to nail down the potential benefits and value of using the radial versus the femoral approach for PCI in ACS. So this is a large trial. It was more than 7,000 patients randomized in 30-some countries to having either the radial or the femoral approach for their PCI in ACS. The main primary endpoint was a combination of death, MI, stroke, or major bleeding using a modified TIMI definition. And to get into the study, operators and sites needed to have a minimum volume of 50 cases radial per year to ensure that they had some minimal experience with the radial access. And some would not qualify this as minimal, but then maybe we can debate this. And as we all know, there's been a lot of debate as to the merits of using the radial approach versus the femoral approach. And I think to some extent it was a surprise that the trial primary endpoint was evenly distributed across the two groups with no major difference in the primary endpoint between groups. So, Dr. King, were you surprised that there was no major difference in outcomes in RIVAL?
I was, because I thought that radial would reduce the bleeding complications more dramatically than it seemed to. And it was not the fault of the radial that it didn't so much as it seems to me the femoral did better than some would expect. And so there are a number of issues there, whether the anticoagulation dosing was more on the friendly side to avoiding bleeding complications than some previous studies. But the fact that the radial, which is clearly favored by patients, favored by many operators, the fact that it in this group of operators didn't overwhelm the femoral was perhaps not surprising, but I mean, I didn't know the structure of the trial when it was going on. I said, you straight up test femoral and radial. I would have guessed that the radial would have done better than the femoral for the complication situation. So that's my reaction to how it came out. My understanding of the trial is that the major difference was an access site bleeding complication, even though it was not excessive, and that's understandable. But our interest, and my interest in trying to understand this is in the U.S. as opposed to some sites in Europe. The operator experience is not extensive for most operators. You talked about 50 cases radial, 50 cases total interventional cases for many people in the U.S. is a fairly healthy experience, not a fairly large experience, perhaps not healthy. It becomes a problem for me as director of a heart institute to decide how far should I push people. We've taken the step of creating a radial lounge. We create a recovery area. We made it very friendly to do radial cases because we would like to encourage it. On the other hand, how do we move operators who have done nothing but femoral? How do we move them to the radial, knowing that their volume is not hundreds of cases a year? How steep is the learning curve? How much trouble am I going to cause by trying to force a femoral guy who's getting by with it, doing okay, to switch to radial? So that's the kind of issue we have. The people who are doing radial all the time do a great job of it, and gradually people are creeping into it. But in the U.S., this may be part of the reason that radial is still probably in single digit, around 10% or something, whereas in Europe it's gone much more fast.
The learning curve may take far more than 50 cases.
Yeah.
In fact, there's some data to suggest it takes more than 50 cases. Dr. Nolan, if there's an experienced radialist, you're a strong proponent of the radial approach. What do you take? What's your take on the results of RIVAL?
The RIVAL trial, I would have predicted the results would be as they were from looking at the way the operators were recruited. So 50 radial cases in a year before you entered the trial is a very, very low number to be an experienced radial operator. So essentially, Rival compared inexperienced radial operators with with more experienced femoral operators, and this would minimize the difference between the two groups. The trial also used a relatively restricted bleeding definition. I think you know, Roxanne, that bleeding definitions can influence endpoints. And if you look only at the composite endpoint, there is no difference. If you look at the acuity bleeding composite endpoint, there is a significant difference in favor of the radial group. If you look only at major vascular complications, there is a significant difference in favor of the radial group. And when you look again at the actual data and the numbers, in the radial group, all of the major vascular complications were in fact in patients who crossed over to the femoral arm. There were no major vascular complications in 3,500 radial patients in Rival. So I don't think Rival changes things too much. Radial access is a way of reducing vascular complications. It's overwhelmingly favoured by patients. When you're consenting your patients for a procedure, if you say to them, we can do it from the leg or the arm, but if we do it from the arm, we will have less complications, very few patients would opt for femoral access.
Roxana, what is your view of the radial? It's been quite a debate, particularly across the pond, between Europeans who are slightly more radial in certain countries, such as this country, where radial is really very favored, and the US, where radial is less used. And in the debate, I mean, there have been some heated overtones because some people feel that when they're using femoral, they're being accused of being all hat, whereas they might view the radialists as using radial mostly for marketing purposes.
You know, there's no question that, we see it all the time now, that the younger interventionalists are really learning how to do radials and wanting to be there to have the edge over maybe even their partners. It's a new sort of technique or a new expertise, an area of expertise that they can claim, and I think that's something that interventionalists may be drawn to. I think we need to go back to the patient, and the truth is that I think patients are going to end up requesting this because once they learn about it and they experience it, they're gonna definitely want it. So I think to say that so Rival was negative and that we should forget about radial, I think is a silly way of looking at it, and I think that we're going to see a lot more radial interventionalists going forward, and I think the U.S. will catch up to Europe in increasing that particular area. But at the same time, I think we're also focusing a lot more now than we did before on meticulous femoral access, and I think that's an important piece to bring out too. I think there are lots of interventionalists who are really using important techniques and being very meticulous about their stick. We're no longer using venous and arterial sticks. It's just as much smaller sheath sizes. Everything has gotten so much better to reduce access site complications. And then all hats are off when we go to TAVI and large bore devices, and that can't be done through the radial access. So my take on Rival is that I was surprised of the results. I really was. I expected to see a major difference because I do think bleeding matters, but that I also think Rival brings out the importance of non-access site bleeding complications, that they continue to play an important role, and they're going to be equally distributed whether you use femoral or radial access, and that you need to still think about that for your patient as far as the bleeding goes.
Now, in Rival, there were subset analyses that were done, and I want to bring up two of them. The first one is there was an analysis that was done by tertile of center experience with the radial approach. Mm-hmm. And from that analysis, there was an interaction between the outcomes, the primary outcome and other outcomes, and center experience. And clearly, those centers that had most radial experience did better with the radial approach, whereas centers that had modest or moderate radial experience did not do as well. So do you think this vindicates the issue that the radialists were not experienced enough radialists in Rival, Dr. Nolan?
Yeah, I mean, I think it reflects the issue of to get the benefits of radial access, you have to be a skilled radial operator. I think that analysis related to operator experience and centre experience was a pre-specified sub-analysis, so it perhaps carries a bit more weight because of that. And I am not surprised to see that the less experienced teams have less success as radial operators. The crossover rate in Rival was quite high, it was 7%, mostly due to spasm. If you look at contemporary series from expert radial operators, the crossover rate is more like 2%, and spasm is a rare complication for experienced operators. So I think that reflects the nature of the radial operators who participated in Rival.
Maybe can I use this time to pause and ask you what is your advice for the cocktail to prevent spasm? What do you use in your institution? And maybe we'll see what others do.
I think it's mandatory to give a spasmolytic cocktail. I think if you look at the SPASM trial, which is a randomized trial of no vasodilators versus verapamil or verapamil and nitrates, there's a clear reduction in spasm for giving verapamil. So in our institution, we actually use a small dose of sublingual nitrate before doing the puncture because it increases the caliber of the radial artery. After the puncture, we instill a cocktail that has 2.5 of verapamil. And prevention is better than cure, so don't wait till you get spasm because then it's much more difficult to deal with. After we put the sheath in, we will always shoot an arm angiogram. Arm anatomical variation is present in nearly 15% of people. It's better to see what the variation is. If you see a big loop, don't do the procedure, go to the femoral artery.
Those are great tips, aren't they?
Aren't they? Any other advice?
I want to bring up another point on the radial side, and I am a proponent of radial, so don't get me wrong because I'm sitting next to this incredible radial operator. But I think we shouldn't forget about contrast use, radiation exposure. Those are the kinds of things that we also need to.
Fluoroscopy time was greater in Rival, significantly greater.
Can I just comment on that? I mean, there is lots of data. There was a recent paper on 7,000 patients published, I think, in one of the American journals. And observational data, there is a clear trend to higher radiation values in the radial groups. But almost invariably, they have compared less experienced operators with more experienced femoral operators. And the learning curve and the expertise levels differ between the groups. Now, less experienced operators, whether they be femoral, radial, whether they be less experienced pacemaker operators, whatever it is, they will always generate more radiation. In our institution, my radiation exposure values for patients and myself are lower than some of the femoral operators. So it is largely an expertise-driven issue, really. I know it's a concern, and radiation is important.
Well, but both also, I'm also very interested in the contrast dose, you know, and if you really have to take a lot of pictures and you're having a lot of hard times. But I think that things are going to get better. You know, the catheters are going to be made much better for the use of radial access and such that maybe we won't be, you know, using more contrast media. But there's no question that in the early experience, there's going to be that also to be dealt with.
There was a contemporary randomized trial published last year that didn't show a lot of difference. I mean, as I remember it, the fluoro time was a minute more or something. The contrast load was a little more. The radiation was a little, you know, but they were trivial differences. So I don't think that's, you know, much of an argument. What you said about your results against the femoralists is why you can't do a trial as a trialist. You must realize this. We couldn't take the expert radialist and expert femoralist and try to test them against each other. That would be very difficult. But one of the things that interests me in this is a lot of the patients we see are acute STEMIs, a lot of acute infarctions. So if a patient is rolling into my hospital, somebody's on call, and I've admitted that the experience level in the UK per operator is quite different than the US, so you've got to understand that. The crossover, even if maybe it's the real crossover is 7% and modest experienced people, I'm not sure I come in with acute infarct. I want somebody to, you know, be messing around, you know, with that and then having to cross over, and so I've got a delay. I'm not getting my artery open. So this again gets back to my concern about how do you, no question, radial is preferred by the patient, so you can get up. Maybe we save money. We're studying this in our institution, trying to evaluate the economic impact for the hospital, same-day discharge by radial versus overnight stay with the femoral, and which is our practice. But again, I'm stuck with the question of how do we transition people who are in practice. No problem with the fellows in training and so forth. They're all learning radial, but it's going to take quite a number of years for them to be the major operators. I mean, the people doing the bulk of the operations. The bulk are going to be done by people who are already in practice. And if they're doing femoral, what is the learning curve? How many cases do you think someone needs on average to achieve the kind of expertise you like to see?
Historically, the learning curve has been very long, and if you look at some of the French operators who've published their learning curves, it has been up to 1,000 cases.
Wow.
Now, that is historical data, and at the time they were traversing their learning curve, knowledge about how to perform radial procedures, about arm anatomical variation, those issues were unknown, really. Equipment was primitive, specific radial equipment didn't exist, and so over time, with more expertise and better equipment, I think the learning curve is shorter, but I would estimate it's maybe 50 cases to be a reliable radial puncturer. And then to get on top of most of the technique, it's probably about 300 cases. After that, you're on a long flat segment of the learning curve, so you still continue to learn, but there is a steep, perhaps 300 case learning curve. I mean, in the UK, over the last 10 years, there's been a sea change in arterial access site practice, so it now accounts for almost 50% of all the interventions done in the country.
50, huh?
And in France, I think it's close to 70.
60,
60,
65.
Yeah.
I want to get back to the STEMI subgroup because it's very interesting, the STEMI subgroup. I would have thought exactly as you pointed out that this is the one area where you want to be quick, particularly if your access times are being monitored and you're monitoring door-to-balloon time, so everybody wants to be quick, and there's no question that it's simpler and probably somewhat quicker to puncture a femoral artery. But on the other hand, the subgroup analysis that was pre-specified for STEMIs in RIVAL indicated a mortality reduction with the radial over the femoral. So if there's one group of patients in whom there seems to be some indication of clinical benefit, that's this group. So what do you make out of this?
You ask about surprise. That's a total surprise to me.
Isn't it?
It remains so. I don't understand. Perhaps someone
there was a significant interaction, a statistically significant benefit, and no major difference in bleeding rates in that subgroup. So we can't explain the mortality reduction from the bleeding rates that were reported using the major bleeding definition.
So then would you say it's by chance?
It could be, as we know, subset analysis have to be taken with a grain of salt, but this one fulfills a lot of the criteria one would use to define a proper subset analysis. It was pre-specified, the statistical interaction was there, the benefit is statistically significant. It's a clinically different subgroup. I mean, STEMIs are clearly different from non-STEMIs. And so my clinical take is if there's one group in which I would insist on doing radial, it would be the STEMI patients.
And it's the same group that you probably need the most experienced operator for all the reasons that I think Dr. King just mentioned. So
on your next visit to the North American continent, however, I would not insist on it because the operator may not have the 50 or 1,000 or 1,200 cases that they need. So it remains a question. I think it's a wonderful way to get to things. You can control the bleeding, and the one thing that is tragic is retroperitoneal hematoma, of course. So to avoid one retroperitoneal hematoma, I would put up with a lot of extended procedure time, a lot of things like that to avoid that. But I do think that this study teaches some other things too, and perhaps the care of the femoralists they took with the femoral cases, which we say, well, maybe this influenced the result. This is not the real world. But if they took good care, if they optimized the anticoagulation so that they didn't create unnecessary bleeding, well, these are all good things. So for people doing femoral approach, they may learn some lessons from this trial as well, that if you're going to do that, you should be held a high standard in terms of complications, regardless of which approach you take.
So we have a clinical message to the practicing interventionists. If you're doing radials, do a lot of them and do them well. But if you're doing femoral, you better be good at doing femoral as well. Well, thank you very much. It's been a fascinating discussion, and I hope our viewers enjoyed it on the Heart.org as well.